that so proudly we hail at the twilight's last gleaming. Christmas lights and bright stars through the perilous skies, o'er the ramparts we watch, were so gallantly streaming, and the rockets red glare, the bombs bursting in air, gave proof through the night that our flag was still there. Oh, say does that star-spangled banner yet wave o'er the land of the free and the home of the brave?
Marhaba. First of all, before I start, I'd like to take this opportunity to thank Dr. Kamal Ben Mansour for his invitation to speak to this professional group, مجموعة التواصل لأطباء الأسنان. And also, I'm very grateful to be part of your group. In addition, a special thanks for Professor Karina Mehanna for her recommendation to Dr. Kamal Ben Mansour so I can be a part of your group. It's really an honor to be associated with the مجموعة تواصل لأطباء الأسنان. During my presentations, I'm going to show you how to make the mandibular to implant overdenture treatment predictable. So I'll be covering the principles of such treatment concepts, and certainly I'll be showing some clinical tips. Hopefully you're going to be using those tips when you treat your own patients. We know for a fact that denture wearers' complaints can be divided into two. Either the denture wearer's prosthesis gonna be ugly and uncomfortable. Ugly dentures can be made pleasing if you follow certain basic guidelines about denture aesthetics. And you can see from these pictures before and after. Also, we know for a fact that Dr. Burns told us in 1995 to make the complete denture successful, they have to be retentive and stable. On the other hand, Redford in 1996 surveyed denture wearers and found out that 50% of their mandibular complete dentures have problems in retention and stability. Are there any treatments available to enhance the retention and stability of complete dentures? Yes. I'm sure you agree with me that treatment with dental implants shifted from a peripheral to a central positions in our daily private practice. Treatment modality, when we talk about mandibular overdentures, you know that we have to fabricate a prosthesis over a certain number of implants. So if you place only 2 implants, that prosthesis is going to be tissue supported and implant retained. And this is where we talk about the biomechanical aspect of that prosthesis. Now, if you place 4 implants and you spread them as far apart as possible, then the prosthesis, the biomechanical of that prosthesis is going to behave differently. And we're going to be talking about the prosthesis is going to be implant supported and also implant retained. And it's going to feel like a fixed bridge, but it's for me, I usually, when I talk to patients, I usually refer to it as a removable type of a bridge. Indication for implant mandibular overdentures, as I said, when there is a need to improve the retention and stability of these prostheses. And certainly in patients with xerostomia, saliva, it's a lubricant, so it's going to decrease the amount of rubbing effect of the integular surface of the denture on the soft tissue, and also is going to improve the suction when you have enough saliva. Certainly when you have a partial loss of a mandible in case of trauma, accident, or cancer, so implants going to help stabilize these compromised dentures. I want to share with you this clinical example. A patient has been wearing denture for so many years and then decided to get new sets of dentures. Went to our dentist and evaluate and told her that the best thing to make her lower denture stable and retentive to place couple implants. But what the problem is, after placing these two implants, patient invested some money. Patient came back to the dentist and said, well, you promised me that my denture is going to be stable and retentive, but it still feels the same way. So when you look at this picture of that patient, certainly you see there is a problem with selection of these ball abutments. The one on the right side has a good cuff height, but the one on the left, it's a problem. It's not enough cuff height. But you have to troubleshoot. So the patients came to my practice and we have to troubleshoot it. So I took the denture and tried to put it in and out. But there is a positive retention that these ball attachments are giving to the denture. But when you look at the anatomy of that mandibular denture, there is a question marks here, question marks that we can ask. Problem with the length of the flanges. And also there are certain primary support area that these dentures should cover. Retomolar pad area, buccal shelf, and so on. So it shorts in the back. And we know for a fact that a retomolar pad will not resorb under pressure because it's the demarcation or the insertion of 4 different muscles in that area. So it's a good positive area to get your primary support. Also the buccal shelf. Buccal shelf is part of that base, bony base of the mandible. It's not going to resorb under pressure. Remember that alveolar bone, when the teeth are out, and if you put pressure on this alveolar bone, they're going to resorb under pressure. But the most important things, now we're going to check the type of occlusion that the patient has. So we're going to ask the patient to put the tongue on the roof of the mouth and move it backward while closing. And we're going to ask the patient the moment she feels the teeth comes together to stop. And then we found out that what happened is on the left side, the bottom teeth will hit and have eccentric contacts, but the right side, no contact. And then we ask the patient to squeeze, and suddenly the mandibular denture will jump on the right side to meet the opposing occlusal surfaces. So you see here the occlusal stability of these removable complete dentures becomes a big factor in the stability of these prostheses. And I will show you, so certainly you have to apply basic principle of complete denture removable prosthodontics and should be respected in implant prosthesis uses. And this is an example of a well-made complete dentures. Good extension of the flanges according to anatomy of the patients, good tight centric, and certainly a good occlusal scheme. I'll be covering what type of occlusal scheme will be beneficial when you make these dentures to get that stability that we need. Remember that 2 implants cannot help badly made dentures, but 2 implants will improve a well-made denture. So designing a successful 2 implant prostheses or 4 or 5 or 6 or 7 implant prostheses, the treatment should start with a successful all on none prosthesis. So this slide tells us that the importance of a well-made pre-surgical denture. And that pre-surgical denture has to be functionally acceptable, not only from an aesthetic perspective, but also from an occlusal perspective. And I want to show you this video. The video on the left, it's showing the existing denture and with unbalanced type of an occlusal scheme. And the setup of these denture teeth are placed according to skeletal class 1 type of occlusion. And when the patient's gonna move left, right, and forward, the suction is broken. So let's watch that video together.
Go ahead, move forward, go ahead, move forward, move forward, a bit more, a bit more. And put your chin down, and put your chin down, chin down, okay. Now, go ahead, move forward, go ahead, move forward. Back, back, right, right, move forward, move forward. Back, back, move forward, back, back, move to the side, move to the side, back, back, move to the side, move to the side, back, back, and move to the side, and move to the side. Okay, that's it. That's it.
So you see that when the patients move left, right, and forward, you lose the suction, and the denture, especially the lower denture, became unstable. And even sometimes the upper denture would become unstable. For the same patients, I fabricated new sets of complete dentures, and I'm going to show you that video. The denture, especially the mandibular denture, becomes very stable, even though I retract the lips and the cheeks and ask the patient to move, to do excursive movement. So let's watch the video together.
Now slowly grind left leg and out. Okay. Very good. Very good. Bite all the way in the back. Chin down. Chin down. And move the chin.
So if you notice, there is no contact in centric between the 6 and 11, between the upper canine, the right canine, all the way to the left canine. So when the patients move left and right, you always have contact on the posterior teeth. So this brings us to what is an accepted occlusal concept. You have to have a maximum intercuspation in centric, in a retruded contact position. Also, when the patients move left and right, you should not have any deflective occlusal contacts. At the same time, you have to have some type of cusps height for selective occlusal reshaping. And in the end, certainly that the tooth arrangement should have a natural and pleasing appearance. So you're dealing with two different occlusal concepts, a fully balanced or lingualized type of occlusion. And this is mostly related when you want to use a three-dimensional tooth anatomy. And so you end up with bilateral posterior centric contact, and you're going to centralize the forces in the middle of the fossa. And certainly in the end, that balanced occlusion is going to minimize the tipping of especially the mandibular denture. Another concept is mostly what we relate to, the name of it is non-interceptive linear occlusion, or AutoCentric type of occlusion. And if you see here, the maxillary teeth, they are not three-dimensional tooth, so they are flat. The premolar, molar are flat. The second characteristic is there is no vertical overlap of the anterior teeth. So the moment that the patient start moving forward or to the left or to the right, the anterior teeth will not clash together, okay? And also the third anatomy of the third characteristic of this type of an occlusal scheme, we use porcelain teeth, and the mandibular occlusal anatomy, if when you look at that picture, is made, the functional cusps are turned into a bladed shape. So when the patient is going to bite down, certainly it's going to improve the chewing efficiency, and that occlusal scheme is going to stabilize the mandibular denture in its basal seat. And I'll show you that video of that occlusal scheme.
Right, right. Tap, tap. And slide, all around, all around, all around, all around. Keep your teeth together and slide all around and forward, back and forth.
So you see here when the patients move left and right, barely the anterior teeth will kiss each other, but they always have contact between the premolar and molar. And you see how nicely is that that AutoCentric occlusal scheme.
Now open wide.
And the aesthetic, you know, when you look, when your patient is smiling, certainly.
Diaploid smiling.
You want to show me some teeth.
Okay.
Turn the head towards me. And smile. Okay, now go ahead, say Mississippi.
Mississippi.
55.
Mississippi.
Very fine.
Very fine.
Mississippi.
1666.
65.
1666.
Very fine.
Very.
Relax. Stay like this and relax. Very good. Relax a bit. Okay. Relax a bit. Very good.
So as you see from that occlusal scheme, you have a good stability of the prosthesis, but also a good aesthetics. And certainly if you apply basic removable prosthodontics, good occlusion, good aesthetic, good lip support, good selection of the vertical dimension of occlusion, selection of the plane of occlusion, and good centric, now certainly you end up with stable dentures. Now you're going to tell me, well, if you have these stable dentures, why you want to use implants? Remember that when we talk about stability versus retention, it's two different ball games, as we say. Stability, it means against lateral forces. So it keeps the denture in its place when the mandible is moving left, right, or forward. Retention is mostly against vertical dislodgement forces. So when a patient's eating some sticky food, certainly the food is going to be sticking on the denture, and while the patient is opening their mouth to chew, then the denture is going to be moving away from the base, from the soft tissue. So remember that these denture wearers, they're going to select the type of food they're going to be eating. If they want to eat everything they can, everything they find in a restaurant, then certainly implants going to improve the outcome, and it's going to resist the action of these sticky food, and certainly the patient's going to enjoy their chewing of this type of food. So let's look at another clinic situations. Can you tell me what is right and what is wrong? Now, certainly everything went wrong here. Not only very poor lip support and so on, the selection of these teeth, the setup of these teeth, the placement of the implant, the selection of the cuff height of this locator abutment, management of the soft tissue, a lot of bony exostosis. The occlusal scheme of that denture is very wrong. So these patients mostly end up suing her treating dentist, and she got a lot of money from that lawsuit. This brings us to at what inclination do we place implants? And you see you have a mandible here, a cross section of that mandible. We can place the implant according to that inclination, or according to that, or according to that inclination, keeping the platform of the implant at the top of the ridge. So what is the best angle inclination? And this is what we talked about it from the beginning of my lecture here, the importance of a well-made pre-surgical denture. Look at that patient's before and look at it after we remade her dentures. So certainly the aesthetics look nicer. We rejuvenate the lower portion of the face. But if you're gonna place an implant according to that old denture, and we want the platform of the implant to be situated between the two flanges of that mandibular denture, and this is the inclination of that denture is going to be. So if you're gonna place it according to the new well-made pre-surgical denture, then the inclination is going to be a bit different, keeping in mind that the platform of that implant is going to be situated between the two flanges of that newly fabricated denture. And because of that, a lot of dentists felt that they have to learn how to make a well-made pre-surgical dentures. So between my lab technician Jack and I designed a course, 2-day course on live patients, how to fabricate a custom-made complete dentures. And we talk about the type of impression technique do we want to use, what type of wax rim will be simplify the making of these wax rims. Sometimes we have to use a neutral zone record, and this is the neutral zone record is going to give us ideas where the placement of the mandibular teeth in case of the patient, in case of lack of a mandibular ridge. And also we show a good way to get the vertical dimension of occlusion and a good retruded contact position using these Gothic arch tracings. And this course is becoming very popular, and we do it at in Sacramento. So, in case you want to place 2 or multiple implant, you have to have a radiographic template. And that radiographic template also is going to be very important in placement of these implant. And this is, we can turn that radiographic template into a surgical template, and the implant placement will be much predictable. For us, a CBCT radiographs is a good diagnostic tool if we have the silhouette of the final destination present during these radiographs. So not only is going to give us the silhouette of the existing bone, but also the silhouette of the final crown, for example, with in coordination with the silhouette of the bone, we can determine the axis of placement of these implants. Another thing that I like to share with you, in 2002, a bunch of prosthodontists met in Montreal, Canada at McGill University and came out with this consensus. So let's read it together. What is the treatment of choice for complete edentulism? So the statement is as follows. The evidence currently available suggests that the restoration of the edentulous mandible with a conventional denture is no longer the most appropriate first choice prosthodontic treatment. There is now overwhelming evidence that a 2-implant overdenture should become the first choice of treatment for the edentulous mandible. So what does it mean? It means that if patients comes to you wearing a complete dentures and he wants a new set of dentures, then your treatment plan is going to be the first, the first choice for treatment planning for that patient is we're going to present to him that we're going to make a new set of denture, but we're going to place 2 implants on the mandibular arch. So this is the new standard of care. This is what they told us. But let's think about it. If patients come to you and wearing a denture and has a very good bone, what is the first choice of treatment? What's the optimum treatment for that patient? Certainly, if it was my mouth, I want a fixed bridge instead of an implant overdenture over 2 implants. So for us, now, our first choice of treatment for the edentulous mandible when the patients come to us is going to be a fixed bridge. And then according to the money available for that patient and the time available in case you have to do some bone grafting or so on, then we can downgrade that treatment option. It can be 2 implant overdenture, or it can be just regular sets denture. So it all depends on the patient's wishes according to the money available for such treatment and also the time involved in doing that treatment. Another important factor that when we place implant, we have to put abutment, and also we have to connect the denture to this abutment through some type of retentive clips and a metal housing. So the inter-arch availability becomes a big factor in our restoration. So the restorative space has to be well thought out according to that pre-surgical denture. So the best way to find out if you have enough inter-arch spaces is during that trial denture of your pre-surgical denture. Studies showing that we need, when you're dealing with a solitary anchor type of a locator, you need at least 12 millimeter of inter-arch space. In case you want to connect these implants together with a bar, or you want to make a fixed bridge, then you need at least 15 millimeter of inter-arch space. So how do you attach the mandibular denture when using attachments? Now, certainly there are 2 different techniques available for you, either in the patient's mouth or in the lab. Studies showing that the best way to attach that denture to the implant is inside the mouth. It's a direct intra-oral technique. When you do it with in the lab, then studies showing that when you place that denture in the patient's mouth, the only thing is going to be in contact is the implant, and you're going to have a space between the soft tissue and the integular surface of the denture. And remember, when we're doing a 2-implant overdenture, that overdenture, the biomechanic of that prosthesis is going to be tissue-supported, implant retained. So you have to have maximum contact between the soft tissue and the integular surface of the denture, and the implant is going to help retain the prosthesis in its place, especially when dealing with sticky food, as I said. So it's very important when you get that denture from the lab, the first thing you're going to do is we don't want these healing abutment or the locator abutment touch the integral surface of the denture, and then we're going to use some pressure indicating paste. And you see from that picture, only a very few area, very small area of the soft tissue is in contact with the integral surface of that denture. But when you adjust it and trim this area and then do a couple of pressure indicating paste painting, as we say, then you're going to improve the contact of the soft tissue with the inside of that denture. And certainly remember, most of the time we have to do a little bit of occlusal refinement, as we say. And the reason why, because when you deal with acrylic, there is a shrinkage during the processing of that resin. So occlusal equilibration is very important at the end, and some people will do a clinical remount to perfect that balanced type of occlusion. And then afterwards, I usually, when you finish PIP and doing occlusal equilibration, I usually send the patient home, and the patient is wearing that denture over to healing abutment. And I want to see the patients usually 24, 48 hours and make sure there is no sore spot. And if there is sore spot, I have to troubleshoot it. Is it because of imperfection of the fit, or is it an occlusal problem? So usually I wait the patient. I usually send the patients back, and after 2-3 weeks, I replace the healing abutment with locators. At that time, I'm sure there is no sore spot. The denture is tissue supported and is going to be implant retained by attaching it to this locator abutment. So that technique has many different benefits. Certainly, you're applying basic prosthodontic principle, and also you have better relation of the attachment to the soft tissue. And then you end up with a better retention and better stability of the prosthesis. And the most important thing, when the occlusion is correct and the fit is correct, you're going to minimize the wear on these attachment, and certainly less frequent replacement of that retentive clip. If you have to change this retentive clip every few months, then there's a problem with the biomechanic of the prosthesis. So keep that in mind. Now, certainly I put these patients on a recall visit every 6 months or once a year, and according to that, we'll decide if the clips need to be replaced or not. So the popular attachment for this type of treatment, we refer to it as locator. Dentists carry this type of attachment with under a different name. It's kerator. And the kerator abutments, they come in a different collar heights, 1, 2, 3, 4, 5, and even 6 millimeter of collar heights. The most popular one is the 3 millimeter collar heights. And it's a one-piece abutment and does not engage any internal connection of your implant. Has a tripod drive feature, and this is important for torquing the abutment in place, but also the inside, it constitutes a retention. And the recommended torque is 20 to 25 Newton centimeter. And so the popularity of that attachment is the patent dual retention design. So you have a combination of an inside retention and an outside retention. So the plunger of that clip will be in contact with that internal retention, and the outside of that clip mostly will give you the outside retention. Dentists carry this 2-in-1 tool for your attachment, and the tool has two tips. One to remove the retentive clip or the black insert from your housing, and the other tip is mostly to insert the retentive tip inside the housing. And also you have to have this torque driver and the screwdriver to torque the abutment in its over the implant, according to the 20 to 25 Newton centimeter. And also remember, depending on the angulation of the two implant, usually 10 degree of angulation problem on each side, no big deal. You can use that dual retention clips. But when it's over 20 degrees on each side, over 40 degree of angulation problem, then you have to get rid of one type of retention. And the one that we have to get rid of is that plunger that it goes inside the abutment. And then we refer to it, the clips, we refer to it as the extended range males. This video, the whole video is going to be available for you to look at it at the GDIA website. But I want to show you at the end of the surgery what I like to ask the surgeon to do for me, especially if he's gonna close the flaps over these implants. So he takes that surgical template, and before putting the flaps together, then he marked the location of these implants. And this is going to be very helpful afterwards during that second stage surgery to expose these implants and change the cover screw to a healing abutment. So here we're going to show you during that second stage surgery what we're going to be doing. Certainly we can use that surgical template, a marked surgical template, place it all inside the patient's mouth, and you know exactly where to make a very tiny incision, and then the cover screw will be replaced by a healing abutment. So healing abutment be selected according to the sulcus depth of that site. Make sure when you place the healing abutment, we don't want to pinch the soft tissues. Now we finger torque these healing abutments, not with the torque driver. Usually 15 to 20 will be plenty. And then we're gonna make space, make hole, so we don't want to lose the fit, the accurate fit of the integral surface of that denture over the soft tissue. So we have to use a medium to locate where we have to drill. So a futar D here, it's a PVS bite, placed, and ask the patient to bite down, wait until it's completely set, remove it. We have to use a medium to locate where we have to drill. So now we know exactly where we have to make these holes. So we remove with the blade, we remove the PVS at these locations. And then we're going to take a permanent marker to mark these holes. So when it's well marked, we're gonna remove that PVS bite. Now we're gonna take a inverted pear-shaped carbide acrylic burr and make these holes. And certainly we do not want the acrylic surface of these of the intaglio portion of the denture to be in contact with these healing abutments. We usually wait 2 weeks at least for the gum to heal around this healing abutment before ordering the abutment, the locator abutments. Because, you know, the abutment cuff height depends on a well-healed sulcus. You don't want to order an abutment and then afterwards the gum is going to recede and the abutment is going to look looking too long and creating some kind of a torquing effect, torquing stress on these implants. So here I'm going to show you a technique how to attach a mandibular to implant overdenture using the locators. So the abutments are purchased with all the retentive clips. The retentive clips and the metal housing, they come in one vial. And this is a 3-in-1 tool, an old tool by the locator company. It has 3 different functions. The gold one is your screwdriver, is the abutment driver.
That's the whole edge. Zoom in now.
So you're going to go ahead and place it over the implant.
Go ahead.
Now we're going to torque it to 20-25 Newton centimeter. We place both housing and we'll make sure that the denture does not, the recesses inside the denture do not touch these metal housing. We want to have at least 1 millimeter of space between the denture and the housing. I always like to put escape holes. And here we're going to show you 2 different ways, 2 different materials used to attach the housing to the abutment. If you're going to use BIS GMA, and certainly you need undercut to make an undercut with that round burr, bonding liquid, and place the BIS back in BIS GMA. And remember, GMA will not bond chemically to the acrylic, so you need to get some kind of an undercut inside these holes, bonding liquid, escape holes. And then we're going to ask the patient to bite back in centric. And then you see how easy to remove the excess of that BIS GMA. And remember that they don't bond chemically, so it's very important to have that retentive undercuts inside these holes and using bonding liquid. On the other hand, on the other side, we're gonna use a cold cure acrylic, and to show you that either ways, it depends on what you select, we can do that. You see my finger is plugging that escape hole. Monomer is placed first, and it's gonna be saturated by a tooth-colored autopolymerizing resin. The reason why I use a tooth color because I want to identify the excess of resin so I can remove it afterwards. If you're going to use pink acrylic, then you have to use a special indicating paste to know exactly where your excesses are. Here we forgot to put that nylon ring spacer, but we can adjust that later. We don't want the acrylic to be in intimate contact between the resin and the gingiva around the abutment. And I like to do one. I like to attach the denture one at a time. Especially most of the time you're going to have some angulation problem, so it's much easier for you to do one at a time. And sometimes you do both in the same time, you might lock the denture in place, and then good luck to remove it, and you have to destroy the denture to be able to remove it. How do I know that? It happened to me, so this is why I'm advising you about it. So we remove that lab plastic clip, and then we're gonna replace it with a very retentive clip. In my clinical experience with my patients, I found out that if you're dealing with a male patients, usually we need a medium retentive clip, the pink one. The blue is the least retention. Pink is halfway, the medium retention, and the clear is high retention. So pink clips for male patients and blue for female patients. So as the patients usually use the two thumb fingers to be able to remove the denture. So we'll let the patient practice a couple times in front of the face mirror.
Now take it out one more time. Now take it out one more time. Okay. Back on. Okay. Back on. That's mine. Okay, Mom, you want a joke? Okay, you want a joke? Okay, it's fine. 55, say 55.
So it's very important to, before you dismiss the patient, to go over all hygiene instructions. The patient has to know that they have two teeth now in their mouth, so they have to clean these implant, clean the abutment, and also clean the ridges and clean their tongue. And we put them on a 6-month recall. Certainly, I usually see the patients after attaching the denture to the abutment. I see them 1 week or 2 weeks later to prevent any problem or to fix any problem.
Put your lips together, teeth together.
So we're gonna show you how to change a locator clips. This is the new 3-in-1 tool by the locator company. I like this one a little bit better than what the dentist has, the Kerator 2-in-1. So you have all three in one. So you have the third one is the driver, and the other clip, this is the driver here. And this tip here has two functions. One to remove the old worn down retentive clips on the patient's denture from the housing. And also, when you remove that portion, you have the insertion tool. So let's see, let's show you how we do it. So you notice that we have to put that retentive clip over that tip, and then we bring the denture to it, and it has to snap in the metal housing. Sharing that problem case with you at the end. Certainly, I don't know what happened here. Certainly, there's a big problem with angulation of these 4 implants. So what should we do? Certainly, you can do a bar, but if you decide to do a locator abutment, you have to do a custom-made, a CAD-CAM generated locator abutment, and you want to make sure that the locator tips, the retentive tips, is going to be all parallel to each other. So True Abutment Company is available for us. So an impression was sent, they scanned the model, and they designed these locator abutment for you, and our two-piece abutment. And certainly what I like to see these picture first before they mill it, and to check it. And when everything is checked by me, it's approved by me, I'll send them an email to mill it. And this is what you see on the model. It's a 2-piece abutment. You have an internal connection, and the connection has to be engaging. That abutment should engage your internal connection of the implant. And you have a separate screw that's going to hold that abutment in its place. And then here it's very critical to attach one attachment at a time. Otherwise,
Mississippi,
you're going to be in trouble.
61, 62, 63, 61, 64, 65, 66, 67, 68, 69, 68, 69.
So in the end, I'd like to thank you for your attentions, and please, I want to share this quote with you, the quote from Mother Teresa. Not all of us can do great things, but we can do small things with great love. Thank you for your attention.